after muscarinic blockade, we really are left then with one acetylcholine receptor to block. And we don't have too much to say here. We want to block nicotinic receptors. We know that clinically we don't like dealing with nicotinic receptors too much. And the only ones we're going to talk about right there are the nicotinic N type of receptors, the one you find in ganglia. Look, there are two drugs you should familiarize yourself with, hexamethonium and mecamylamine. These two drugs are not used clinically at all, so they're truthfully for your step one and nowhere beyond that. These two drugs are used in problems, and they're used in ANS problems because they will prevent baroreceptor reflex changes in heart rate. So that's where you're going to see them. That's how you should really review them. As far as their true effect in the body, just in case you were using them, well, what you know you're going to do is literally wipe out the entire ANS. And as you wipe out the entire ANS to try and figure out what the results would be on vegetative function, just imagine you remember what is the predominant tone on the system, then you cancel that predominant tone. For instance, sympathetic is the only branch of ANS that innervates the vasculature. It is responsible for the vasoconstrictive tone of the vessels. If you shut down sympathetic, you'll see dilation, with its consequences of hypotension, decreased venous return, and so forth. You know, in effect, if we were practicing, I don't know, 5 decades, 6 decades ago, then drugs like mecamylamine were actually used in hypertension. They're just no longer used for that because of the multitude of side effects coming from ANS blockade. Pretty much anywhere else we'll see parasympathetic predominance in the body. For example, in the heart, the pacemaker is through parasympathetic, so we'll tend to see tachycardia. With the eye, we'll see mydriasis because parasympathetic is predominant. You know what's really relevant here that is really in a way missing in the notes because I want to tease it out of you right now in the video. The idea that you are not seeing tachycardia because you're leaving sympathetic predominant. Remember, it's cut off too. So we're seeing tachycardia because now this is the true intrinsic rhythm of our heart. It wants to go fast. And it is because of parasympathetic that we maintain it at its regular rate to match the hemodynamics. So maybe what is relevant to understand is if you were putting that patient on a treadmill, do you think that heart rate would increase? How about if you were putting that patient on a sofa and letting them rest for 20 minutes? Do you think it would decrease? I hope you're answering no to both situations. The idea is that tachycardia is fixed. It is not to decrease, not to increase anymore, simply because there's no more autonomic regulation of this parameter. It is the same for the pupil. That mydriasis you're looking at, it would not increase any further by putting the patient in a darker condition. And certainly as you flash a pen light in the eye of that patient, you will not see meiosis either. There is simply no ANS tone. So providing you have this ready, just finish the table briefly. Parasympathetic is predominant everywhere in the body except the vasculature and also the sweat glands. And canceling the ciliary muscle will result in blurred vision. In GI-GU tract will decrease the motility, and in glands will dry out every single gland. This is not where your board is really going to cause you problems with hexamethonium and mecamylamine. It is much more with the issue of the baroreceptor reflexes. So here we've devised a little algorithm for you to work with in advance of checking out our problems. And as you look at this algorithm, here's the deal. Imagine you have a drug that is working in the heart tissue itself. Maybe it's working on a muscarinic M2 to cause bradycardia, or from our next chapter, maybe it's working on a beta 1 to cause tachycardia. Let's place on this diagram ganglionic blockers such as hexamethonium and mecamylamine. You recognize here the ganglion? This is where hexamethonium or mecamylamine would be working. They would be blocking the nicotinic neuronal receptor that is found at the autonomic ganglion. Well, blockers have no efficacy. So do you think that putting that drug in red, where it's located on the diagram, would prevent the drug in purple from binding its receptors and causing the effects? Of course not. It cannot prevent the drug from reaching the heart. All it does is block at a different location a neural pathway. It'll never affect the purple drug and its binding and responses through muscarinic or beta receptors. So look at the statement underneath. Ganglionic blocking drugs do not prevent any change in heart rate that was caused directly by the drugs. And the key word here is directly by the drug. This is a drug that is either working through a beta-1 receptor, causing tachycardia, or through an M2 receptor, causing bradycardia. Essentially, what I'm saying is, if I see a tachycardia in a problem, and I don't know whether it's the drug or the reflex causing the tachycardia, let's look at the situation now in presence of a ganglionic blocker. If I still see the tachycardia, whether the ganglionic blocker is there or not, it must be a beta-1 agonist. Bradycardia, it must be a muscarinic agonist. Contrast. Let me take a bright yellow drug, and that bright yellow drug is actually not working in the heart. It is working in the blood vessel. It's either working as a vasoconstrictor or as a vasodilator. So obviously what it's doing is changing our blood pressure. And as blood pressure changes, we know baroreceptors will send this information to our brain, to vasomotor centers. And what will the brain do? Try and use baroreceptor reflexes in order to reinstate the pressure as it was prior to the drug administration. To do this, the reflex must travel through the actual ganglia to reach the heart. And if it has to travel through the ganglia to reach the heart, would my hexamethonium in red on the diagram blocking the ganglia interrupt that reflex change in heart rate? Of course. It would behave exactly like a pair of scissors, just chemical scissors, and it would interrupt the neurotransmission and it's reaching the heart. Let's take an example. I'm using a vasoconstrictor. This vasoconstrictor is increasing blood pressure. In increasing blood pressure, I need to trigger a reflex. Are you saying bradycardia? I hope you are. I'm supposed to trigger a reflex bradycardia, which is through parasympathetic and muscarinic receptors, slowing the heart to try and lower back the blood pressure. Well, hexamethonium would cancel the reflex bradycardia. It would never block the effect of the drug on the blood vessel, because hexamethonium does not bind to receptors on the vasculature. So here's a statement here. Ganglionic blocking drugs will prevent reflex changes in heart rate that are due to vasoconstriction or vasodilation. And in advance of the chapter we're about to get into, that would be respectively alpha-1 or beta-2 receptors. Don't panic too much. I know this is a complicated section, and you'll see we're going to review it over and over again with several examples, not only in the next chapter, but also while we're going to practice problems at the end of this ANS section. The sooner you get it, though, the better off we're going to be.